Hi, my name is Nicole Sherrard. I am a student at the University of New England, and I am presenting on the impact of school-based intervention on health and wellness parameters in Turkey and the Turkish Republic of Northern Cyprus as part of my Applied Nutrition capstone for APN 755. An introduction to Turkey and the Turkish Republic of Northern Cyprus, which is also abbreviated TRNC. Turkey is a country bridging the continents of Europe and Asia, while the TRNC is the northernmost part of Cyprus Island, which is approximately 40 miles south of Turkey. Turkey and the TRNC have a close relationship. Turkey is the only country that recognizes TRNC as a sovereign state distinct from the Republic of Northern Cyprus, which governs the remainder of the island of Cyprus. So the TRNC relies on Turkey to provide vital support for a lot of functions, including the import of food. Turkey and the TRNC have increasing rates of poverty and inflation, limiting the access of healthy food for lower-income families. Research shows a positive correlation between income brackets and nutrition literacy, which impacts eating patterns. Schools provide a platform to deliver nutrition education across all socioeconomic backgrounds. The synthesis of evidence from developing countries, including Turkey and the TRNC, is limited, mostly due to funding and lack of teacher training. However, research from developed countries shows positive results. My PICA question is, do children or adolescents in Turkey and the Turkish Republic of Northern Cyprus that are offered school-based nutrition interventions have improved health and wellness parameters compared with those who do not participate in school-based nutrition interventions? The specific aim of the scoping review is to understand the effectiveness of school-based interventions in Turkey and the TRNC by mapping educational, environmental, and multi-component interventions and their associated nutrition-related outcomes. We searched 14 databases following the PRISMA extension for scoping review guidelines. We searched specifically for peer-reviewed research in English and Turkish. The publications that we found were from 2010 to 2025. The search terms that we used included elementary, primary, secondary, children, adolescents, Turkish Republic of Northern Cyprus, Turkey, Turkish, Turkey in Turkish, program, education, nutrition, diet, school-based interventions. Looking at the PRISMA diagram, our initial search of literature yielded 360 publications. After excluding duplicates, the titles and abstracts of 90 publications were screened and 40 selected for full-text screening. In total, there were 25 research papers that met all inclusion criteria. Looking at inclusion-exclusion criteria specific to population, we included school-aged children, approximately age 6 to 17 years old, examined in Turkey or the TRNC within the school setting. Exclusion criteria were students who were not of school age, students who are not studying in Turkey or the TRNC. For interventions, inclusion criteria was anything school-based addressing nutrition-related aspects, whether educational interventions, environmental interventions, or multi-component interventions. And those excluded were interventions not based in schools and interventions that did not address nutrition-related outcomes. Outcomes for inclusion criteria looked at anthropometrics, an increase in nutrition knowledge, and/or behavioral outcomes, and those excluded measured non-clinical related outcomes. Looking at results, specifically study demographics, the grades ranged from 1 to 11 in the literature. The median grade was 6 to 7. All 25 of the research papers included males and females, but only one measured the difference in outcomes between the two. For location, 23 studies took place in Turkey. Only 2 did not specify their exact location within the country, and the other 21 took place amongst 10 provinces, with the most in Ankara, followed by Istanbul. And there were only 2 that took place in the TRNC. The number of schools per study was 1 to 6, and the duration of study was 1 day to 6 months, with the average of 1 to 3 months. There were a variety of study designs, including 10 quasi-experimental, 8 single-group pre-post tests, 5 traditional randomized control trials, 3 cluster randomized control trial, and 2 hybrids, so a cross-sectional and randomized control trial, as well as a cross-sectional single intervention pre-post. There were 4 common trends across the literature as far as nutrition and wellness parameters. The most common was nutrition knowledge at 21 of the 25 research papers, and they commonly measured and looked for significant improvements to food groups and nutrients consumed, knowledge, healthy and unhealthy foods, and then reading label knowledge. Eating behavior was the second most common nutrition and wellness parameter, with 20 of the research papers measuring this. A lot of research looked at meal routines, reducing sugary drinks and snacks, as well as healthy canteen choices. The third most common nutrition and wellness parameter measured was nutrition attitudes, with 11 of the research papers measuring this, looking most often at benefits of healthy eating, self-efficacy for making healthy choices, and or positive views of fruits and vegetables. And last, there were 5 studies that looked at BMI for significant improvements and measured physical activity recommendations, energy balance, and limiting sedentary behaviors to meet reduction in BMI. Looking at the 4 different nutrition and wellness parameters, I created a bar graph that shows the different study designs and maps them to the outcomes for each of the parameters. So knowledge and attitude improved across all study designs, whereas behavior did not significantly improve in quasi-experimental, and BMI did not significantly improve in randomized control trials. Looking across the literature, there was clear trends in why BMI and behavior did not improve. And those trends were short intervention duration. They were under 12 weeks. No follow-up or no long-term follow-up. So studies that have follow-up were at 3 to 6 or under 6 months, and it takes 6 to 12 months at minimum to see improvements when specifically measuring BMI and behavior. The education provided was brief and more traditional to lecture style, so there was no interactive components. And there was no changes to the environment, so no healthy offerings, or no subsidized meals, for example, to facilitate that behavior change. There was minimal parent involvement. So there were 5 studies that included passive parent involvement. They received nutritional education at home and optional invites to events. And these did not result in any significant changes. Also, theoretical frameworks that either weren't present or they had poor integration, meaning that they didn't fully integrate them into the lessons as part of the intervention. And then low intervention intensity, so only a few sessions with limited reinforcement. trends in studies with the strongest significant findings pretty much showed all the opposite. So they had longer intervention durations over 12 weeks, so longer exposure, and long-term follow-up at that 6 to 12 months. There were 3 studies specifically that have follow-up after 1 year, and they all showed significant improvements in all of their nutritional wellness parameters. Active programs, so that would include visual tools, games, hands-on activities, and engaging instructional programs such as peer support or group work. Multimodal learning would include different instructional approaches, so combining kinesthetic learning with visual or auditory, for example. Environment support within the school, so maybe there were those healthy canteen adjustments, modified school rules so they couldn't have sugary snacks, and then active parent involvement. There was only 1 study that included a comprehensive parent engagement where parents were part of the education intervention and received learning material after. The study not only resulted in significant improvements in behavior and BMI, they resulted in the most strongest across the studies, which really speaks to the active engagement of parents. And then structured application of the framework, so that they weren't just mentioned, they were actively applied through goal setting, skill practice, self-efficacy building, for example. And then guidance from healthcare professionals was also really important, whether it was a dietitian or a nurse or a researcher that was an expert at public health. If they were engaged in the intervention or helped develop the material, it was much more effective than teacher-led. Limitations of this research from a country perspective, both Turkey and the TRNC do not include free or subsidized meals, which is a huge concern in the country right now and a barrier for behavior change if those in low-income tax brackets can't purchase food. And then from a study design, although there were improvements in nutrition knowledge across all the studies, they were all identified through self-reported assessments by students, which increases the risk of social desirability bias. And then future research, parents and teachers and active participants in the intervention group, we wanted to include them in the intervention group, but there just wasn't enough research. And then compliance with national and ministerial programs. There were 5 studies that did this, and they all found significant improvements. And then more research in the TRNC. My conclusion was the synthesis of school-based interventions conducted in Turkey and the TRNC shows significant improvement in health and wellness parameters that were primarily seen when interventions include applied theoretical frameworks, active learning strategies, school environmental support, parent involvement in interventions, and guidance by healthcare professionals. These are my references. Thank you for attending.